events, and this kind of builds from that a little bit, and I wanted to go through some differential diagnosis between adjustment disorders through post-traumatic stress disorder, really focusing in on the trauma and stress-related types of diagnoses. Okay. So our session objectives are, as always, the same: to evaluate individuals with comorbid physical conditions. And we love technology, we really do. To distinguish level of care needed for complex cases, and to be able to educate patients, families, and others to normalize mental, emotional, and behavioral aspects of mental health conditions and reduce stigma. So traumatic event, for diagnostic purposes, because this becomes important when you're looking at, is this adjustment disorder, is this acute stress, is this post-traumatic stress disorder? A traumatic event, as defined by the DSM, would be exposure to actual or threatened death, serious injury, or sexual violation in one or more of the following ways. So that would be directly experiencing the event or witnessing the event, that possibly would happen to a close family member or somebody in the vicinity, learning about the event if it's happened to a close friend or family member, typically of a more violent or accidental nature. So, a longer term illness of somebody that we kind of expected to come, you wouldn't consider a traumatic event, despite the fact that it is clearly distressful. And then repetitive or extreme exposure to aversive details of events, but that wouldn't typically be through media exposure unless that's work related. So what they really mean there is like a person who has been sexually violated, who then has to tell the story to a counselor, who has to then tell the story to an attorney, who then has to testify in court. So the more a person has to go through all of the details of an event, the more likely they are to actually hit that level of this being more traumatic. When it does come to media, that would be people who typically have to interface with this kind of stuff as part of their profession. So police, counselors, social workers, physicians, anybody in the judicial system can get a lot of exposure to really horrific things that maybe didn't happen to them or somebody that they knew or cared about or loved, but just this nature of being inundated with all of this violence and trauma can become a traumatic event in and of itself. But what does that actually mean? So trauma can be a whole lot of different things, from death and a long-term traumatic grief to injuries and illness, traffic accidents, through medical trauma, somebody having to be involuntarily hospitalized, or watching a parent suddenly go into some type of medical illness where they have to get taken to the emergency room. Trauma could be natural disasters. So hurricanes, obviously, tornadoes, house fire. It could be displacement. So think about immigrants and refugees, and sometimes people getting displaced from where they typically live and not by their own choice. Historical trauma, which really looks at kind of a longer term impact of being a family member in a family that has ever experienced at some point in time a huge amount of traumatic stress to that family, and then continues to suffer from it. So we really think about historical trauma in terms of like the children, survivors of the Holocaust and their children and their grandchildren, the African American community, Native American communities, refugee communities, all have this epigenetic change based on the massive amount of trauma that their ancestors actually experienced before them. So you don't ever have to even go through the events to have been impacted this on a much more longitudinal basis. Foster care, I also put up here because I think of that when I think of displacement. When I've worked with kids who have been in a residential setting or been in foster care, you have to take a trauma-informed perspective simply because we should assume that if you've had to be removed from your parents and placed with strangers or in a residential facility, that has to be traumatic. And whether or not the kids would verbalize it as trauma, it certainly would be. Abuse, anything from physical abuse, sexual abuse, or emotional abuse. Neglect, domestic violence, witnessing domestic violence. And school and community violence. So what I think about there is, guns and the amount of gun violence that we've seen in schools and that we hear about in schools, and that teens and young people are clearly trying to take a stand against now, which I think is super awesome, to bullying and the long-term effects that we know bullying can have on kids. So some of the things that put you at the strongest vulnerability to developing actual post-traumatic stress disorder, a large study actually just found that those things are being female. Females are much more likely to develop it. Having events that involved interpersonal violence, and any kind of pre-existing anxiety or mood disorders before the worst traumatic stressor. So somebody who is predisposed to, a low-grade anxiety or maybe a slight depressive episode who then experience some type of major trauma is much more likely to develop diagnosable post-traumatic stress disorder compared to somebody who is fairly well-functioning and didn't have any other pre-existing mental health issues. So I thought that this was kind of interesting because when we think about trauma and PTSD, we don't necessarily think about some of the most common ways that it could happen. So this was a study that looked at families who were in some type of traffic accident, and then they separated out, was the child hurt, was the parent hurt, was nobody hurt? And then they looked at them 5 and 12 months after the traffic accident to see the rates of those groups that actually had diagnosable post-traumatic stress disorder. And if both were injured, you could see that blue bar, the rates were pretty high. I mean, so 5 months after, nearly 30% of people had some type of PTSD. If it was just the child that was injured, less than 20%. If it was just the parent that was injured, that rate was higher. Now, what's really interesting is that when you look at that 12 months later, when it was just the child injured, after 12 months, maybe 7% of them were still displaying some PTSD symptoms. But if just their parent was injured, they were at a much higher rate. So probably twice the rate of, if they were injured versus if just their parent was injured. So thinking about the impact of familial incidents on some kids and how it's really easy to say, well, that kiddo wasn't hurt in that car accident, but their parent was, but the kiddo should be fine, right? Not so much. So what that study really shows is that the effects of injury will impact a child's functioning negatively, even that injury on parents and or siblings. So their general quality of life is going to be very much impacted by what's going on in their family around them, whether or not it is a direct effect on them. So complex trauma then, it's a little bit different. It's the term that's used to describe the wide range long-term impact of exposure to multiple events. And stuff like this, when we see it, it typically tends to occur in proximity to the caregiver relationship. So when you're in a scenario where a child is being exposed to a high level of abuse by somebody that's supposed to be a caregiver over a number of years, what you see is that this actually turns into complex trauma. So it's severe and pervasive. It is going to have a huge impact on the disruption of that child's development and their sense of self. And it can impact their level of attachment to people around them, which is really important for social, emotional functioning, physical health, and mental well-being later on. So looking specifically at the DSM diagnoses for these trauma and stress-related disorders, I wanted to start with adjustment disorder because that would be your lowest level of trauma or stressor related. And within the diagnostic criteria, you notice that it's actually the development of clinically significant emotional behavioral symptoms in response to a stressor. So to be diagnosed with an adjustment disorder, this is any stressor. It does not have to be a traumatic event. It can be a change in school. It could be moving from one location to another in a non-threatening way. Just your family buys a new house and you're going to move across town, but you didn't even have to change school. That could still be a stressor for a lot of kids. Changing grades can be stressors. So an adjustment disorder would just be something that an event happened that was deemed stressful by the child, and their level of distress and impairment is out of proportion to what would be expected. And adjustment disorders present in a lot of different ways. It's kind of an easy diagnosis to give when you don't really know what's going on a whole lot with the kid, but they definitely don't have something huge, but there's something that you need to work with. So it can present as a depressed mood, as anxiety, as mixed depression and anxiety. It could present as a disturbance of conduct, and it's typically looked at as acute. It can be considered persistent, but personally, I think if you're getting into a persistent adjustment disorder, there's other things that you really need to start considering of what's really going on to get a clearer diagnosis. An acute stress disorder is when we jump into something that we would have to determine is a traumatic event according to diagnostic criteria. So not just any stressor. And this would be something that would happen, not long after the actual stress event or the traumatic event happened, and would last anywhere from 3 days to about a month. It's the quicker, shorter version of post-traumatic stress disorder, the stuff that usually goes away fairly quickly. So once you've hit that past a month level, then you have to start looking at what else is really going on? Does this still meet an acute stress disorder level, or are we actually dealing with PTSD? So where PTSD would be developing of those symptoms after a traumatic event, but these things last more than a month. And sometimes they don't actually present themselves until a full 6 months after the event occurs. So that can be more complicated, because, especially with younger kiddos, because then you're trying to think about, well, what happened 6 months ago? If you can't even identify what the traumatic event is, and sometimes families aren't very good at doing that, or if a child has been through foster placements, they might not have the best history of what happened 6 months ago. The new family might not know everything. Even caseworkers might not know everything. So it can get a little bit complicated when you're trying to piece together what exactly happened to determine whether or not it can be PTSD or not. So because all of these are so related, I wanted to look at the symptom clusters by themselves, and really that difference between acute stress disorder and post-traumatic stress disorder outside of a timeline is going to be in the level of dysfunction and impairment in these symptoms. But you have clusters of symptoms, so these would be intrusive things, like the dreams, nightmares, dissociative reactions like flashbacks, persistent involuntary thoughts and memories. Kids can express these as maybe not necessarily content that's overtly related to the trauma, but some type of dreams or nightmares that are just distressful of nature is sometimes what you'll see for intrusive symptoms in kids. Avoidance symptoms, so that would be the persistent avoidance of really anything that could be a potential reminder. So any external stimuli, conversation, places, people, as well as internal things that would potentially remind the person of the trauma. And sometimes you will see some of this stuff occur in the children's play. So reenactment in play, or distressing types of themes or content in play activities. Another chunk of symptoms is arousal and reactivity. So this would be irritability and anger, physical, verbal aggression. So a kid with a number of outbursts, hypervigilance, an exaggerated startle response. I feel like I'm really guilty of that all the time. I jump very easily. Problems concentrating, and sleep disturbance. So the sleep, you can see disturbance from the intrusive symptoms in that maybe they're not wanting to sleep, or they're trying to avoid sleep, and they're having bad dreams, but then they might not even be able to fall into sleep or have weird patterns of sleep. You also see mood and cognition changes, so possibly the inability to recall important details, negative beliefs about the self or the world around them, negative expectations of what may happen, inappropriate self-blame, developing some detachment and social withdrawal or disinterest, so you'll see kids disengaging from play activities, and a persistent state of negative emotions or a lack of the ability to feel or express positive emotions. Now I put this in here because depending on the age of a child, that might look a lot different than what we would see in a teenager or an adult, or even a slightly older age child. So on the left, you see the possible symptoms for kids 0 through 2. So acting withdrawn, demonstrate poor verbal skills, but they might not have great verbal skills at that time anyway. New and excessive temper tantrums, aggressive behaviors, poor appetite, poor sleep, maybe screaming or crying excessively, startling easily. In children 3 through 6, you see a bit more. So then you see wetting the bed, startling easily again, lacking self-confidence, imitative behaviors. So you're starting to see the potential for them to reenact things in their play. Fear of adults and fear of being separated from adults that they consider caregivers and safe people. Aggression, things with learning disabilities that maybe they're not picking up things, learning as well as they would, or as well as their peers are. Being anxious, fearful, avoidant, excessive outbursts and temper tantrums again, and demanding attention for both positive and negative behaviors. So the last chunk of symptoms in DSM-5, they have broken this out as there's post-traumatic stress disorder, which some of the intrusion symptoms sound a little bit like what we would consider dissociative, like flashbacks, but they've given a whole specifier to dissociation that would include depersonalization and derealization. So depersonalization would be those persistent recurrent experiences of feeling detached from your body or mental process, kind of like you're an observer to your own surroundings, or a sense of unreality, your body not being real or things around you not being real, or a sense of time moving very slowly. Derealization is specific to the experiences of unreality in your surroundings. So feeling like your surroundings are distant or dreamlike or somehow distorted. What's interesting is that there was a study that looked at how much does this translate to teenagers, because we know that teenagers can experience dissociative symptoms, and we know that teenagers can certainly be diagnosed with PTSD. So what they found is that if you just looked at the depersonalization and derealization components of dissociation, you actually might miss a couple subgroups of teenagers, because teenagers might actually express dissociation more as amnesia and avoidance. So it's important to do a very thorough assessment and figure out what exactly is going on with these kids, because they might have some dissociative things that don't look, or that they don't quite know how to describe as adequately as we would see in an adult. So really screen. And there's a number of screeners that are available. These are some that are listed. I found all of them pretty quick, and when we share the PowerPoints and any of the handouts, there's links to all of the things that I found and all of the resources that I was able to pull from. So there's a lot of different options. Having good, thorough, open conversations and being aware that there's probably a lot more trauma going on than we assume and that we see, but the screeners will let you do a bit more diagnostically to help you figure out, is this somebody that needs something more intense, or is this something that should kind of be able to work itself out on its own. And next week, to follow up on this, we're going to talk about some of the interventions that can be most helpful with these types of populations, so people with trauma and stress-related disorders. And those are some of that. So thoughts, comments, questions?